Greetings, everyone, and welcome back to this session. My name is Shams Said, and I'm the unit head for quality of care at the World Health Organization. And it has really been a privilege to work with THET colleagues over the last few years in relationship to institutional health partnerships, to institutional panel to listen to this morning or wherever you are, whatever time it actually is. So I will have the privilege of facilitating, but the wisdom really lies in the panelists, and we are going to cover continents related to the work that the colleagues have been taking forward and leading. So you'll see that the descriptions of the speakers are there. I'm not going to read that out. And please do take a look at the speakers rather than about the speakers. So please do take a look at their descriptions. We're going to be traversing telemedicine in Myanmar, well-being of health workers in Ethiopia, the impact of COVID on quality of care in Sierra Leone, and delivering early interventions into developmental disability in Western Uganda. So you can see we're straddling various settings from colleagues that have been leading the partnership work. This morning, we heard from Dr. Rudy Eggers the different aspects of our work in institutional health partnerships at the WHO. And one of the things that came out from that was the real insistence that we should be looking at quality of care issues. But of course, quality of care is not a silo. Quality of care is at the heart of service delivery and health systems. And this is where the power of partnerships can really take hold. And it's tough. And as we were just hearing from the moving testament from our colleagues in Somaliland, it's hard work, but it's important and it really needs attention. So without any further ado, let's start to hear from colleagues. And our first up on our panel today is Thet Win Aung from the Cambridge Global Health Partnerships, and he'll be speaking to us on telemedicine in Myanmar. Thet, over to you.
Thank you. Thank you for letting me to join this interesting conference and very privileged conference. So please allow me to share my presentation first. So good afternoon and good evening, or good afternoon and good morning again. I'm going to briefly present about the Telemedicine Project in Myanmar or Burma. So my name is Thet. I'm a program support for Myanmar program in Cambridge Global Health Partnerships. So the Telemedicine Project is operating in Burma, Myanmar. Basically, Myanmar is one of the Southeast Asian country which has a shared border with Bangladesh, India, China, Laos, and Thailand. It has a 54 million populations, and it is a home for more than 130 ethnic groups. One of the characteristic features or unique feature of my country, Burma, is the country which has the longest civil war in the world. In more than 17 major big ethnic armed groups are fighting for self-determinations. So it's quite interesting thing is that many major ethnic armed groups, they have own ethnic health systems to provide healthcare services in the ethnic their control area. So basically, the healthcare systems in peripheral area of the Burma is very fragmented. So the military coup happened in Burma in 2021, and majority is nearly 70% of healthcare professionals from government hospitals joined the civil disobedience movement. As a result of that movement, healthcare workers were arrested, and also many hospitals were also closed. Additionally, many patients and across the country and in ethnic young group areas, they are unsafe to travel to receive the health services in hospitals and clinics due to the skirmishes and arrest by many armed forces. So Myanmar became one of the most dangerous places in the world to be the head worker at the moment. So let me briefly update you or describe about the telemedicine project. So the project has started in June 2021 with 15 doctors and one IT specialist who refused to work under the military administrations. The aim of the telemedicine project is to provide alternative means of health services provisions during the crisis. But however, it has a lot of potential to scale up in future. So basically, the telemedicine services and program is relatively new and not familiar by users and provider. So it has many challenges. However, it's amazingly, the program has grown very quickly. Now we have nearly 200 volunteer doctors and 20 specialist clinics are operating right now. So basically, the team and the system is built entirely online. It's quite interesting and unique. We never met each other in person because of the security issues. So what's the role of Cambridge Global Health Partnerships? Basically, the Cambridge Global Health Partnership, we have a long-standing relationship and partnership in Burma since 2013 and 14. But unfortunately, after military coup, many of our program has been stalled. But in August, we have a request to support the telemedicine project, and we received the funding from Tropical Health Education Trust Debt. So what's the role? Our role is coordinations, facilitations, financials, and technical support and project management. So in terms of approaches, achievement, and challenges, so as I mentioned before, the telemedicine is quite relatively new in Burma. So we use user-friendly systems for clinicians and patients. And right now, the telemedicine services is running in 10 hours a day and 7 days a week. And we have already provided the services to more than 99,000 patients, including patients in ethnic group control areas. So in September 2021, and we conducted the user and provider satisfaction survey. It's very encouraging result. More than 90% of respond that they are very satisfied with our services during the crisis period, and they also said that the services also met the expectations, such as easy to communicate, not prolonged waiting time, and prescribing prescription and necessary drug. Those are a lot of positive feedback we received. And we also invite East of England, the stroke telemedicine team, and also invite experienced clinicians who are Burmese diasporas in UK and other country. East of England stroke telemedicine team and experienced clinicians are providing technical assistance and trainings and guidance to the doctors and healthcare professionals in our telemedicine services to make sure that the guidelines and treatments are in line with the international standards and protocols. In terms of challenges, there are a lot of challenges, but I'm going to highlight only 3 challenges. One of the biggest challenges is internet connections. We are facing frequently slow and interrupted internet connections during these days. And then also another challenge is frequent electricity outages. The last challenge is what we are facing right now is political instability. So the healthcare providers in our telemedicine services are not very safe right now because of the military coup. So these are the nutshell of our telemedicine projects, and thank you for listening and attention.
Thanks very much, Thet, for that. Just jumping in very clearly to give us an overview of the telemedicine project that you have been working in Myanmar. Turning now to Noah. Noah, you're going to tell us a little bit about well-being of health workers in Ethiopia. Over to you, Noah.
Thank you very much. Hello, everyone. Let me share my screen. Okay. Can you see it? This is Noah from Ethiopia. Currently, I'm coordinating the National MHPSS Mental Health and Sexual Support Unit at the national level for the COVID response and the returnees also for the conflict-related emergency response. So to forward to the point, in Ethiopia, after the COVID pandemic, we tried to initiate different kinds of programs, including the one I present now. It contains two parts, emotional resilience workshop and emotional resilience program, which is followed by the workshops. So before going to that, to give you overview, after the COVID pandemic outbreak in Ethiopia, we initiated healthcare workers well-being program, different kinds of program, including the individual counseling, for face-to-face and hotline counseling service for the healthcare workers to assure the quality and to support healthcare workers to sustain their well-being. And we also initiated different kinds of programs, including self-help materials, self-care book in collaboration with WHO, and different kinds of books in the treatment sites, in the quarantine sites, in the isolation sites. Also, we initiated group counseling specifically for those who are tested positive. So these are some of the initiatives that we applied during the pandemic. After that, we developed the new emotional resilience workshop program in collaboration with the Global Health Program, which is led by David. So we try to initiate this program, which is mainly aimed at to manage emotions, develop resilience in such adversities. So it helps them to manage emotion, develop different types of resilience techniques. Also, it helps them to cultivate different strategies to manage or to ensure their emotional fitness. Lastly, the objective of this workshop or program was to develop facility level or organizational level emotional resilience program, which I'll address at last. So we do this by harness their emotion instead of suppressing, so they do have the time to vent their emotions, and we do this by including the professional and the emotional tone of their capacity in their work and within themselves too. Also, when we talk about how we also help them to help themselves or understand being aware of their emotions, and also this will help them or lead them to help also others within their circumstance or their colleagues or their co-workers. Also, the emotional resilience workshop or this program helps them to manage their emotion and increase their resilience capacity. At last, when you say how it explore what they take into team, which increase their team spirit, teamwork, especially during COVID pandemic. The most problem was the team spirit, the connectedness was affected. So it helped them to reconnect with their colleagues, with their families, and within themselves. So the core principles were it was not lecture, just lecture. It was learning by doing. We believe that in this program that they are experts by themselves. It is non-directive, which is not directive, and it empowered trainees or participants of this program. Also, it involves different multicultural endogenous technique, including coffee ceremonies during the implementation of the program, and it is very flexible. Saying this, the program have these three procedures or pillars or contents, we can call them, which support them during the workshop and during the whole program. So to show you some of the activities, the modalities, one, indoor sermons, which means indoor lectures, it contains different activities, outdoor activities. It contains also some savoring exercise, which is more related, help them to back to the nature, back to childhood, which means it helps them to restructure their thoughts, which help them to calm and think things what they're engaging or things that they go so far. This is also the savoring exercise. These are our most senior physicians, those who fight COVID-19. So we help them also to savor or gratitude during these workshops. Lastly, after the work, at the end of the workshop, we help them to develop emotional resilience program according to their respective facility. So we adopted the Dr. Susan model, which integrate the specialized service, which integrate the peer support and establishment of unit or center. So these are some of the activities that we initiated in the health facilities to help healthcare workers manage their well-being, like of establishing wellness center or wellness steering committee, reading corners, annual different festivals, visits, tours, and wellness coffee chat. So in the coffee chat, they will share their idea, their emotion, their feeling, and there is also laughing corner, and different activities are integrated in this program. So these are some of the activities in picture while they do some physical fitness exercise. This is Ekakotabe Hospital, one of the major COVID treatment center. This is the book center or the book corner. And this is the group counseling and individual counseling center, which include also different kinds of paintings. So briefly, this is, thank you very much. Amasakkanallah.
Thanks very much, Noah, for that, and really clear and important work on emotional resilience, and clearly has implications on quality of care. We're now going to turn to Dr. Callie Tan. So, Callie, over to you.
Good morning, good afternoon, good evening, wherever you are today. It's a pleasure to have been asked to talk today, really on behalf of our teams within our partnership in Uganda and Rwanda. Let me just share my slides. I'm sorry, it doesn't seem to want to share. I hope that you can see those slides now on your screen. So I'm going to talk today about supporting quality care for children with developmental disabilities during the pandemic, and specifically focusing on challenges, solutions, and finally a little bit on silver linings. I'm the programme lead for the Baby Ubuntu programme, which is now becoming an international programme of early care and support for young children with developmental disabilities. So how do we deliver on high quality care and support for children and families? Well, we developed the Baby Ubuntu programme as part of a group of programmes that are available online, freely available. Ubuntu meaning a sense of togetherness or belonging, a sense of I am because we are. And this programme was developed with families with a child with disability around these 5 pillars: promoting inclusion and participation of children with disability within the family and community, maximising developmental potential, optimising health and quality of life, promoting empowerment of caregivers through information sharing and peer support, understanding the child and family experience, particularly addressing discrimination, exclusion and stigma, and of course promoting the human rights of children with disability. And as such, you can see it is a social model of care as much as it is a medical model. And the programme itself is a 12-modular participatory group rehabilitation programme facilitated by an expert parent and an allied health professional together. And it uses a participatory approach to training to engage families and to make learning practical and fun. And the vision for the programme is for inclusive families and communities supporting young children with developmental disabilities to thrive. And I highlight this because it's as much a community intervention as it is an individual family intervention. And I think that's really crucial to the impact of the programme. Where is the programme running? Well, we have vet partnerships across Uganda and Rwanda now, and other adaptations happening around the world. We are having a sister programme running in South America for children with congenital Zika syndrome. We are adapting in Fiji for children with preterm, for high-risk preterm infants. For Afghanistan, we have a programme called Mighty Children now, which is an adaptation for humanitarian settings. And we have very strong UK links and a platform of South-North collaboration to adapt the programme for high-income country settings. And this is just some of the teams that I'm very much reporting on their behalf today. Our trial team in the bottom right, bottom left, in the bottom right, the Mbale team in eastern Uganda, the top, the Chiwoko team in central Uganda, and some components of all of these teams are also working in the western Uganda team in Fort Portal. So thinking what have the impacts of the pandemic been? Firstly on children and families, we certainly saw a prioritisation of COVID response over other aspects of health, and this was particularly important, I think, for this very vulnerable population who themselves were very vulnerable to COVID infection, and the risk of difficulties from COVID, but also through limitations to access of care. Lockdowns prevented the meeting of our groups. It undermined the peer support, which is absolutely central to the programme, and that was immensely challenging. And of course, at times we just had to stop the groups entirely. How did we respond to that? Well, wherever possible, we maintained communication links with our community and community visits where they were possible, or even through phone calls where that was not possible. We developed COVID-specific guidance for running groups, and certainly in Rwanda, we very quickly got back up and running. You can see here that we meet outdoors. There is mask wearing, and we adapted guidance from the African CDC guidance and provided PPE for our families to ensure that we could keep moving with our groups. Transport was a really key challenge in attending the groups, and often we had to run much smaller groups during the pandemic. We had to adapt our facilitator training and our training more broadly. There's 2 levels of training that we do. We train healthcare workers and community health systems workers, if you like, village health teams, in identification and care for children with disability. But we also have to train facilitators for our programme. And we had to train in much smaller groups. We had to adapt our training virtually. We had to we had to think about the de-skilling of programme facilitators when the programme was not running, and we had to run refresher training. Supervision and mentorship is really crucial after training to make sure that people maintain their skills and the fidelity of the programme is maintained to ensure quality delivery of care. A lot of that moved to social media groups and virtual platforms instead of face-to-face, and actually that's been highly successful and will continue even now we are able to go back to meeting face-to-face. And finally, we developed a tablet application to really help support fidelity with a more animated, interactive modality than the manuals that you can see in the top right-hand picture, that's really supported us in the times of COVID. And this is Sam on the left, a fantastic project coordinator in central Uganda, Shwoko, who started a weekly radio programme around child disability during the pandemic to really ensure that we were continuing to advocate for our children, continuing to communicate, continuing to keep disability in people's thoughts and minds, really. And finally, community and other stakeholders were really important. It was really challenging for ministries of health. We worked very closely with the RBC, for instance, in Rwanda, who were really overwhelmed with the COVID response. We found alternative approaches to stakeholder engagement, one-to-one meetings in the absence of the large conference-type meetings that we like to hold. And it's really exciting to be able to be getting back to some of those bigger meetings now for networking and planning going forward. So silver linings, it's difficult to talk about silver linings when it comes to the COVID pandemic, which has been so deeply traumatizing for so many people around the world, wherever you are from. But I do believe in this quote by Leonard Cohen, which is, there is a crack in everything. That's how the light gets in. And I think there has been cracks that have come along with COVID. And I think we've adapted our ways of working. I think moving to a more online profile. I think we've improved our communication with our colleagues and partnerships. I feel like we have empowered our Ugandan and Rwandan teams to be more autonomous in their working, and I think that's been fantastic. And I leave the last word to one of our mothers who said, before the lockdown, group members, we were like families. We encouraged each other. We encouraged each other as we all had the same challenges. But during lockdown, we were not able to meet and share our experiences as we used to. Like me, I felt alone because of the community and some family members' stigma. As we get back together in groups, we are happy together. There is still stigma, but at least I do hope that once or twice a month I meet with my colleagues, which is one of the happiest moments for both me and my child. And I think that's the vision of moving back to quality of care for us going forward as we come out of the pandemic. That just leaves me to say thank you to all our sponsors, partners, stakeholders, and of course, our families at the centre of the work that we do. Thank you.
Callie, thank you so much for bringing that to life so beautifully. Colleagues, if I can ask all panelists to unmute and put their video camera on, so we just have a discussion to just unpack a couple of the points that were made so eloquently by all of you. So we've heard around the telemedicine issues, we've heard around mental health well-being and emotional resilience, and we've just heard from Callie in terms of early care and support for children and families. So one question that I'd like to pose to each of you, and maybe taking it in reverse order, starting with Callie, then turning to Noah, and then to Thet, is when you look at the partnership work that you're involved in, clearly there is a link, a central link with the quality of care that's delivered. How do you think the experience just in the recent painful period will change the trajectory of your partnership work? what do you think the priorities will be for quality of care in your respective areas? So, Callie, if I may turn to you and then come to Noah and then to Thet.
Yes, thank you, Shams. I mean, I think it's been a time of incredible growth for us all, as well as the difficulties and challenges we've faced. I think the teams in Uganda and Rwanda have adapted so fantastically in the delivery of a quality service and measuring that quality. Many of the ways that we delivered and evaluated the programme have been undermined by lockdowns and physical distancing and community visits and facilitated feedback, and all of those things became really difficult. We've really learned to invest in and exploit digital communication, and I think that's going to be a strength for us going forward. Social media platforms like WhatsApp, don't mean to product place, but have been hugely influential in us maintaining our links with our families and communities and teams, and has made communicating with them more immediate and more effective. I think in certain ways supervision was challenging, but I think we've learned ways of immediate supervision. I think we've learned ways of working across borders without traveling, and I think that's a strength. I think, our carbon footprints are less. We've learned ways to support each other and work together that don't require face-to-face. I think the offset of that is that lack of water cooler moment, that lack of being together to innovate. And I feel that is a loss. But overall, I think there is much to take forward that will improve the quality of our care and our programme. So I think, there is silver linings, absolutely.
Yeah, really important points, Callie, and a number of them there. Noah, turning to you, I mean, just in your description, it's very clear with emotional resilience that was taken forward. How do you think that will affect quality of care issues in Ethiopia?
Thank you very much. Majorly, as mentioned before with other speakers prior to this session, the mental status or the mental well-being of individuals, which means the healthcare workers, is the most essential and center of any quality. It can be health quality, whatever, any quality, kind of quality, which means in the COVID pandemic, we learned the most things that are under the healthcare workers' responsibility, most of the things, as we know. So, assuring their mental well-being will give us two things. One, will assure the quality of the service for the patients or COVID patients, those who tested positive. And the second, it will help the healthcare workers by themselves. So the quality issue will be supported both for the patient and for the healthcare workers. And lastly, that such initiatives or focusing on the well-being will help also the institutions, because most of the institutions after the COVID pandemic, the shock gave them a lot of lessons, and one of the lesson was, did they have a resilient healthcare workers, which means a resilient facility that can maintain any kind of shock. So not only helping the healthcare workers, helping the patients by helping the healthcare workers, and also it helps also the organizations or the health facilities to sustain, to manage any kind of shock by managing their healthcare workers or health force well-being. If I addressed
so nicely put, so nicely put, Noah, and very clearly bringing out the resilience of individual workers within a resilient facility and the effect that has on quality of care issues. So that's really very, very interesting. Thet, turning to you, over 9,000 patients seen through the telemedicine work. How is quality of care examined, and how might this affect the future?
Yes, the quality in our project, the quality of care is really important. Even we are delivering the service through through the online. So in the case of the Burma, we faced unprecedented pressures and uncertainty as a result of coup, conflict, and COVID crisis. So it's, the healthcare system in Burma is very already poor. That poor healthcare system became more deteriorated, and it's struggling to provide the service at the minimum level of quality. In telemedicine project, we could use simple way to measure the quality of care and prioritize the quality. The simple way means listen the feedback of user on services and setting up senior medical teams and committee to review to and assess our medical providers are following standard treatment guidelines and protocols. This is the way what we are trying to make sure that we are providing quality of care to our user.
Thank you so much. That's very clear. And the role of those standards and those patient-reported experiences can perhaps not be overemphasized, particularly in evolving telemedicine approaches. So maybe turning to, and in reverse order, thinking through another point that may be worth examining together, is when you look at quality of care issues in the work that you are doing, what's the biggest challenge that you see in the work that you are doing in your partnership? Maybe highlighting challenges can help us to define the pathway forward. Just maybe turning to Thet first, Noah second, and Kali. Thet?
In our case, we are delivering the service through our internet platform and channels. So in our case is that the internet connections and unfamiliar of service user to software and platforms are really challenges to provide the quality services. In the meantime, for the security of the reason, some our providers are not able to switch on the video, so the interactions between provider and user is quite limited. So sometimes it's a quality. It can also impact to the quality of the care. So these kinds of challenges we are facing right now as well.
Very clearly put. That. Turning to you, Noah, on the same question.
Thanks. I think very shortly there was a number of challenges, but the major ones were the first one is Ethiopia mental health and psychosocial support. Even before the outbreak, it was not that much the focus of area for us health. So that was the first challenge, and most of the time that we spend after the outbreak was by advocating even what is mental health, what is psychology, what is psychosocial. So telling this to the seniors, healthcare workers, understanding the need, the demand, the first thing, and the first thing that we faced as a challenge. That's the first one. And the second one, after the advocacy, which means after the health facilities accepted our ideas, our initiatives, the second challenge was availability of mental health professionals, because we don't have that much mental health professionals, especially in the health facilities. So this was also another challenge to implement the program. So we try to deploy mental health professionals in those facilities and cascade implement the program. And the last one is when we start this initiative, it was in the actual work area, in the treatment centers, in the quarantine centers. And it was also another very challenging thing throughout the time. We changed the setting and we make it more advanced. So these were the three major challenges, and similar with others, network problem, linking, that's also an issue for it.
That's great, Noah. Thank you for sharing that. Just turning to Kali and on the same question, but I'd just like to add another one that's come from the participants in terms of what perhaps from the work that you've been doing, what can the English NHS learn from the work that you've been doing? Callie, please.
Yes, so I think there's huge opportunities for South-North learning, and I think it probably comes back to the thing I was going to say about challenges. There's been diverse challenges, but what I've really learned is our need to be adaptable, and I think we're still there. You know, what works this week for quality might not work next week if another lockdown comes, or that, you know, we've had such a shifting landscape in the last 2 years about how to respond and when to respond, and I think the answer to that is to use your partnerships. Partnerships are fantastic for shared learning, and that depends, you know, from anywhere in the world. So the Rwandan teams have supported the Ugandan teams in paternal engagement, and the Ugandan teams have supported the Rwandan teams in community engagement. And I think that has been a real power for us, a real powerhouse of the partnerships to ensure quality and ensure that we can rapidly respond to things that change. And, you know, talking of things that don't change quickly, the NHS doesn't always change quickly. And, you know, I think we're also moving into an understanding that this has been a shared experience around the world, the pandemic, and it's been different for everybody, but it's also been trends have been the same. And I think there is a lot of shared learning. I think we don't do early care and support well always in the UK. For the youngest of children, I think we are very good with high-level specialist care. I'm a neonatal intensivist. But this sort of peer support of families at the deepest level, hearing the voices of families, listening to their experiences and adapting our programme to respond to their lived experiences can be done anywhere. And I'm really excited about these opportunities for our families in Uganda and Rwanda to inform and hear from families in the UK and about how we can adapt in that across those divides as well. So yeah, good questions. Thank you.
That's great, Callie. And for sure, the points that you're making on shared learning just naturally tie us up very beautifully to this last question that I'd like to pose to you just before we could close, is if there was one nugget that you wanted colleagues to walk away from your personal experience to apply in their partnership on quality of care, what would that one nugget be? And maybe turning to Noah first, Thet second, and Callie to round us off. Noah?
Can you repeat it once? I lost you.
Just one thing that you would like to highlight for colleagues to walk away with, learning from your experience, one quick point that you wanted colleagues to walk away with from the experience that you've had.
Yeah, I think if you ask me one, we need to have not only a resilient health facilities, but also we have to also address the resilient capacity of healthcare workers and all the health forces in the health facilities. So without addressing the resilient capacity of healthcare workers, health force, we cannot achieve any kind of response, even any minor response.
Noah, perfect nugget. We walk away with that image of a resilient health worker, even in the midst of seriously painful experiences. I think we've just lost that. Callie, over to you.
I would say chief from our learning is nothing about us without us, keeping the recipients of your work at the centre of what you do and hearing their voice loud and clear, being inclusive broadly of all of those stakeholders and horizontal in the sound of their voice. And also we're better together. You know, we're just always better together, aren't we? Bringing these partnerships together to learn together an event like today is hugely powerful.
Beautifully put. We're always better together, indeed. Thet, last word. I think you may be on mute, Thet.
Yes. The last word from my side is that, you know, that there are so many rhetorics and definitions and informations about the quality of care. But, you know, the main challenge is how to transform them into the real practice. So that's a real challenge. So my last word is that it's necessary to make things simple in order to be practiced in the resource poor setting like Burma.
Beautifully put, that everyday quality of care beyond principles. And in fact, this simplification part couldn't be more important than today. I think actually that just reminds me of something that Emerson and Thoreau had a conversation once, and Thoreau was saying, well, we need to simplify. Emerson turned around and said, one simplify would do. So with that, we're going to close this session. It's been fascinating to hear from these three experiences. I know that we'll all be walking away with many ideas for action. Thank you again to the wisdom that's been shared by the presenters, but of course, all the work from the partnership that's gone into the wisdom that's been shared. We'll close now and look forward to the next session.